different durations of antibiotic therapy for treating clinical, and stress that they must have clinical signs, urinary tract infections in female dogs. And the premise is to try and do that in a safe way, to try and manage it with lots of different centres without having to randomise each case to different groups, without having to potentially compromise the care. So the way we're doing it is to stop the antibiotic treatment on Sunday, and I'll explain a bit more about that. So Lisbeth produced the Danish guidelines and was involved in the ISCAID guidelines, but there's also the Protect Me poster, a SAMSOC initiative. And in that, and this was the latest version, and we published just before the ISCAID guidelines came out, we were saying that recommendations for management of uncomplicated, or what's now sporadic cystitis, would be to treat for 7 to 10 days. Now, was based on the 2011 ISCAID guidelines and the available evidence at the time that this poster was produced. But I think that we're probably moving away from those recommendations and saying we can get away with shorter time durations. And the ISCAID guidelines, as Lisbeth outlined, coming out at about 3 to 5 days, so much shorter courses. And if we look at the human side, and some excellent work being done by Brad Spellberg, one of the infectious disease specialists in America, human, he's written an article that really says shorter is better when looking at antibiotic courses. And these are just some of the examples of comparative studies where they've looked at short duration versus long duration to treat community-acquired pneumonia, ventilator-acquired pneumonia, pyelonephritis. And you can see that the treatment, or the groups in the short treatment arm, are doing as well in all these randomized control trials. And there are multiple trials demonstrating this for all these different conditions in people. So hopefully, and one imagines and extrapolates, that the situation is going to be the same in our patients. And we do know that continued antibiotic use is contributing significantly to our overall antibiotic use. So if we could halve our treatment course, we would effectively potentially be able to halve our antibiotic use. And anything that does that will reduce environmental exposure and remove or limit one of those drivers for antimicrobial resistance. So something that I think should be important to all of us, given the threat from that. So for SOS UTI, we're looking to recruit female dogs. They should be 6 months to 10 years of age. We're trying to avoid too many that might have neoplasia as the cause of their signs. And they must present with compatible lower urinary tract signs. So pollakiuria, dysuria, or hematuria. We've taken periuria out of that. And ultimately, if presented with those signs, and it seems perfectly reasonable, and this is in the ISCAID guidelines, vets may decide to use antibiotics. So if that's your plan, and you think, well, actually, presented with this case, I am going to use antibiotics to manage this case, then that case could be enrolled in this study. So if you're saying, well, actually, we're going to go and do radiography, ultrasonography, we're going to wait for the urinary culture before we make a decision, then they would be excluded. We are looking to include animals where an empiric decision to use antibiotics has been made. So we are not relying on culture. That isn't to say that, as with the Protect Me guidelines, that culture isn't encouraged, and we would still, we have ability to collect that data as well, but it isn't considered essential because we are trying to reflect what's actually going on in clinical practice. So if we do a study that relies on culture results, it may not be relevant to the decision making that we're actually facing on a day-to-day basis. So we want this to generate findings that we can actually apply in a true life situation. We're going to be using CASTR, an electronic data platform, to collect the data. So anybody who is interested in participating in this study, I'm really hoping that we can get as many people involved as possible, then we can log you into this system. You get your unique identifier, and you can input the patient data in a very safe way and a secure way for that patient. So it's GDPR compliant, it's all anonymized, and it meets a high level standard suitable for medical research. And this is what one of the pages looks like. And you can see they are just very easy to fill in options, and you can quickly enter the relevant data for each patient that you're treating. And we've got different sections that you can complete for each patient that is enrolled in the study. The objectives of this study really is to compare the outcome in terms of clinical resolution. So how do these different groups achieve a successful outcome? What percentage of cases? And we're comparing different durations of treatment, and we're going to use amoxicillin clavulanate. Now, I accept that the latest AMEG guidelines maybe would push us towards using amoxicillin rather than amoxiclav, but our experience and speaking to a lot of people, amoxicillin is not always available. It's not common practice. So at the moment we have decided to run this trial using amoxiclav, and it will be of different durations. We're also going to look at recurrence rates. So if you use a shorter course, do you then get the problem back within the next 3 weeks? So it is a very simple study, and there isn't going to be much involved from the patient perspective. They come in and they will have a physical exam and obviously detail signs consistent with lower urinary tract disease and a potential urinary tract infection. And the vet is deciding to use antibiotic. Now, if they decide to do radiographs, abdominal ultrasound, that is fine, and they can enter that data. And if they do culture, they can enter that data. But the animal is only enrolled if they make a decision to use antibiotics on the day of arrival. Okay, and the day of presentation will determine how long an antibiotic course they get. So if they present on Monday, they will continue with antibiotics until the Sunday evening. If they present on Wednesday, the same applies. They will have enough antibiotics to complete the course on Sunday evening. And that is important because vets aren't always as available on a Sunday as they are on a Monday. So effectively, these animals are fully treated over the weekend and they come off treatment by Monday. And that's when the vets are back open again, and we can hopefully get an update from the owner, and we can make sure that we're not under treating animals by giving them shorter courses. So it's a safety net approach, is to stop treatment on Sunday, and the length of treatment will be defined by the day that they present. There is a follow-up required on the Monday via telephone, and we have got automatic surveys that will be emailed out to the owners, and they will verify the clinical resolution at 7 days and 21 days after completion. And you can see that if you come in on a Monday, you end up with, better move myself out of the way, 14 doses. If you come in on a Friday, you might end up with 5 or 6 doses, depending on whether you're a morning or an afternoon consult. And ultimately, we've got a lot of different groups, and we're going to try and analyze and compare and see if there is any difference. It is, in effect, a non-inferiority trial comparing all these different groups. The mathematics of that is slightly beyond me, but we have done sample size calculations and estimate that we would need 940 cases to actually achieve a robust comparison. So we will really need the whole of SAMSOC to get involved in this project and to embrace it, and hopefully try and recruit some of these cases. We have got ethical approval. That's we've had this for about a year actually through the University of Nottingham. We've been delayed a little bit by COVID. We've also got an animal test certificate from the VMD to use amoxiclav in this way. If you are interested, if anyone out there would consider participating in this trial, then it would be great if you can let me know. And so either just send me an email, fergus.alton@willows.uk.net, or via the Liz, via the SAMSOC site, that would be grand as well. There are going to be opportunities for certain people to act as a regional hub and maybe support a group of vets in their area. So if you are working in a practice that maybe doesn't see much sporadic cystitis, then it might be appropriate for you to promote this study among local vets and supervise, guide them in collecting the data and running this trial. There will be opportunities for authorship if people want to get involved. We've talked to JSAP about this, and they have got specific guidelines. So we'd rather you get involved early on so that we can comply with those guidelines if people are keen to be part of that study. But I think the point of SAMSOC, or one of the main aims of SAMSOC, is to get involved in clinical research, to try and answer some of these questions so that when we are getting talks like we've had today, it can be backed up by robust data. And as vets working in practice, we can maybe answer some of these questions, provide that data, and improve antibiotic stewardship. Because if we can support that recommendation to drop from the Constantine 7-day approach down to a 3-day approach, that would massively reduce our antibiotic consumption, and it would reduce the threat from AMR. So something that's, I think, could help us all. Thanks for listening, and I really would be delighted to have any feedback on this project. If you want to email me, then please do. I will get back to you, and we'll go from there. I don't know if Andy's got any comments, or James wants to jump in at any point, feel free.
A couple of questions, I guess, to clarify, Ferg. There's a question about what happens if things present over a weekend, and those we obviously can't include. No. We took the decision that 1 or 2 day courses was probably going to be pushing our luck a little bit too much. So these can only be things that present from Monday to Friday. What happens if clinical signs are still present on the Monday? And that's then when it comes down to clinician discretion, really. Obviously we'll record where you're getting to at that time, but then there's no limitations on what you can do with these patients. You then would likely take the view that either you're going to be extending the course or investigating further as to why the dog may still have clinical signs. What else have we got? Questions. What is the incentive for GPs to get involved? Well, we hope the incentive is that we want to try and push forward the evidence in this area, and I think that is something that has a benefit to all of us, really, in the future, both individually and in terms of our opportunities for improving antibiotic use overall. So we hope that acts as enough of an incentive. There are also, hopefully going to be opportunities for people that get very involved then to get, authorships and things on the paper. And we're really keen to hear from people that, want to get involved with the project. This project will succeed or fail on the basis of how many people throw their weight behind it. And this really is one of those projects where we need a lot of dogs. Consequently, we need a lot of people. And, really we want to try and get tens of interested vets who are going to be collecting these cases.
And we have got 40 or 50 already. We wrote an article, Andy and I, that was in Companion a few months ago. We had great feedback from that. So there are some very keen vets out there who I think will do that. We will make sure that any vet that helps with the study will be acknowledged on the SAMSOC page. We can't offer financial incentives for the study, unfortunately, because we just don't have the funding. And we hope, as Andy said, that it is for the greater good. We don't want to burden people. I guarantee that the study shouldn't add significantly to the amount of time it takes. We will provide all the material you need in terms of consent forms to ensure that owners are signed up correctly, and the guidance as to how to use the caster system. It shouldn't add significantly to anyone's workload, but it would be, I think, hopefully fun to be involved with, and it will generate some data that could really help vets in general, and by extrapolation it could help anyone who 10 million of us per year will die of AMR or multi-drug resistant infections by 2050 if we don't up our game on the way we're using antibiotics at the moment. So we've got to be part of the solution.